It's my phone. Hello, hello. I gotta find us in the group. Hey guys, I don't know if anyone's on with me. I got two on. There you are. Give me a wave. I can't tell if you're on Facebook or YouTube, but it looks like I got check marks up top that I am live around all those things. I just have to figure out how to pin us to the group, and then my attention is all yours. Okay. Where are you? Okay, wait. Pinned to featured. I am pinned. Okay, guys. Hello, Barbie, Shirley. Very cool. Tanya. There's Tanya. Awesome. How are you? Debbie, welcome. Great. I can see all the Facebook coming up here. No, sorry. I see YouTube here, so I'm going to bring up Facebook so that I can watch the comments there too. And that way I won't miss a thing. I got my comments here. Okay, cool. Looks like I can handle this. As I said to Laura, as her last text back and forth before she went to bed, since I'm 6 hours behind, or 5 hours behind, I guess. Hello, Lynn. Welcome. I make sure I had all the things because I usually do this on Zoom. So Tanya usually is joining me on Zoom. So she knows I'm good at that. This is new to me. So what I did, guys, is I did screenshot the question. Screenshot. Is that the right word? The questions that were on the graphics. So for those who had asked ahead of time and aren't able to join us here live tonight, then I can get to those questions. But this is also the opportunity. Hello, Heather from New Zealand and Lynn Marshall. Feel free to put the questions on the side here, and I will find them in the Facebook community. Sorry, the YouTube community here, and hopefully the Facebook community here, and we'll rock on. So since it's the first time in the menopause app community, I'll give you a little bit of a explanation for why I'm here, and what I can do and what I can answer and how I can be of help to you. So this live was born out of actually one of the first posts that was in this group. I think it was this one. Kind of this one, how it morphed into this one as the app launched. And Kim just posted a question, kind of tell me what you're dealing with, what's the hardest things that you've come across so far in this menopause transition, if you're in menopause. And as I was reading through the hundreds of comments, I was like, wow, I think everybody just needs a real good masterclass, because it just felt like everyone was struggling with a lot of the same things. There's a lot of information out there, but sometimes it's really hard to know how to navigate the whole thing. So there is an abundance. I mean, it seems like menopause is the hottest topic around. So there's an abundance of information, and I think it can get really, really overwhelming now with all the information to kind of weave through it, figure out what works for you, what might be helpful for you, what is the truth about hormone replacement therapy or the herbal supplements, or not using hormone replacement therapy or not using the herbal supplements, and what can we do with diet and lifestyle and all the things. And so you have me for as long as you want me. An hour tonight, granted, because I only get an hour in a night. But we keep running these for as long as it's still needed. It's still wanted by the community. I'll keep doing them in this community. So once a month is how it rolls here, that I can get away so far to do one on a regular schedule. My schedule is a little bit wonky. So a little bit about me. I am practicing gynecologic surgeon. So I don't do OB. So I'm not an OB-GYN, just the GYN, gynecologic surgeon. I've been in practice now for, 14 years. I was in private practice for 12 of them. And now I'm, don't worry, Lori, you're not late. You got it. We just got started. I'm just explaining why you're listening to me. So I've been in practice for 14 years, and was in private practice for the first 12 of those. And in the last couple of years, I've joined a faculty practice where I focus more on teaching. So my practice is also still seeing patients for surgeries. That's the most of what I do. And I teach now fellows and residents how to do what it is that I do. So I was blessed because my fellowship was with a fantastic mentor who also was a reproductive endocrinologist. And he did a lot of the early work with the things that we have surrounding hormone therapy and the like, and more or less the real science that's come out of it in the last bunch of years, predating the WHI. So the big study where people kind of stopped doing the research, he predates that stuff. And he just recently retired because he's now in his 80s. So he was working way back when this all was going down. So anyway, we did a lot of hormone replacement therapy when I was a fellow. I learned a lot about that from him. As again, I would consider an expert in the field. So I'm very comfortable with hormone replacement therapy and all of those things. And I've had that really developed and honed in on throughout my first 12 years of practice, because my private practice was mostly the perimenopause transition patient population. So when women stopped having babies, they transitioned more into gynecologic care for sure. And so I was doing a lot of general gynecologic care and taking care of a lot of women in the perimenopause, menopause transition, and all the woes that go along with it. And I have to say, we learned a lot together. My patients were my best teachers because I learned so much in talking with them about the struggles, because at that point I was older, but I was still having my babies. So I was in my late 30s when I finished when I finished fellowship and went into practice. And so I was having my babies, but I was learning a hell of a lot from my patients who were going through the transition. And we kind of all grew up together. And then as I ended private practice and was in menopause myself, it was excellent that I had all that knowledge from the past. So this is why I'm here, at least in this capacity. I'm here as part of, I was here as part of Sculpted Vegan as a coach when we entered the world of menopause shreds. So for those who've been around, the OG who've been around for a long time, when we first did the first menopause shred and Laura was looking for some coaching support, I thought it would be a really nice fit. It blends all the loves in my world of taking care of women, gynecology, hormones, and all that good stuff with fitness and bodybuilding, which has really just been fantastic. So I've watched an evolution with the Sculpted Vegan into Sculpted by Kim is the latest, and Sculpted Menopause over the last, I guess it's been 4 years since I've been with the company, but only recently more so in this capacity. So that's why we're here talking tonight and what it is I can offer. I pride myself on an ability to weed out information for you. I mean, some of it is, going to be based on physiology that I know, and I can bend that to try to make sense of some of the things that are out there. Most of it is from what I read. I read a lot. I have a personal interest in all this stuff, so I read a lot about it. So I'd love if you have some menopause myths out there and you want me to do some myth busting, I'm happy to do it. Let you know what really works from my experience, give you some advice for dealing with some of the things that you guys put down on that graphic that are the things that you're dealing with the most. So I do have a live question here from Christina that I want to start with, mostly so I don't lose it. So Christina, Christina's question is, I eat 95% plant-based diet, eggs sometimes, and my cholesterol has been consistently high for the last 2 years. The total and LDL are both high. I'm 1 year in meno. Any advice? Yes, ma'am. So first, let me take you back for a second as to why this happens. I'll take the question off if I can. Yep. So what happens in menopause is that both LDL cholesterol, and I think you said your total, yep, your total and LDL. So the bad cholesterol and the total cholesterol go up together. And what can also happen as HDL, or the good cholesterol, can go down. So that can make the ratio between the two higher. And as the ratio between the two gets higher, that's when we worry about our cardiovascular risk factors. And so that's what we're looking at when we're looking at all those numbers on a lipid panel, is what we call it. I would admit to you, looking at a lipid panel for me left my education about 16 years ago, right? Since I graduated from medical school, the only thing I've focused on, oh my God, it's more than 16 years ago. Okay, it's been 20 years. So 20 years ago when I graduated from medical school. So I always tease patients and I say, my knowledge of treating cholesterol ended about 20 years ago. And that's in the pharmaceutical realm. But I can tell you how it is in the physiology of it. And so when you look at the panel, they add some new nifty things that I'm not so great on the nuance of, but the good old fashioned tried and true total cholesterol, LDL cholesterol, triglycerides, and HDL are what I look for. And what happens in menopause, in the perimenopause to menopause transition, why women's cholesterol will begin to get higher in that transition is because estrogen is responsible for some of that fat metabolism, cholesterol metabolism. And so it does protect you by keeping your HDL numbers higher and your LDL numbers lower. And so then after menopause, you can see this shift in where the LDL gets higher and the total then gets higher together. What can also happen is that because of insulin resistance, which is all part of the mess going on, so you become more insulin resistant in menopause. Then what happens also is triglycerides can get higher. So the fats can then be bound to more sugars, and that can be of heart health and health overall. Jeopardy as well. So those are the things that are happening because of the lower estrogen. So what helps that? So certainly dietary is one way, but of course, I'm sure you've heard from your doctors, X, Y, or Z, watch this thing in your diet. And to be honest, that data changes all the time, but it's part of it is the cholesterol that your body makes, and part of it is the cholesterol that you ingest. So you only have control over the ones that you ingest. So you just want to be careful with the ones that you do ingest, follow the latest guidelines for lowering your cholesterol in that capacity. But hormone replacement therapy has been shown to decrease the impact of hypoestrogenemia, or the loss of estrogen in perimenopause and menopause, to lower that impact on cholesterol. So you can see an improvement or a stabilization of that cholesterol on hormone replacement therapy. So if you are a candidate, Christina, for hormone replacement therapy, it may be something worth discussing with your provider. If you were looking apart from diet, apart from hormone replacement therapy, at just natural supplementation before considering any of the cholesterol lowering medications, the other things to do would be to consider the supplement red rice yeast. And so it's a tablet. And if you just search for her on Amazon, whatever your search engine of choice is, you'll find the red rice yeast supplement. And that has been shown to decrease cholesterol levels. So if you're looking at all the things you can consider, if you're, hopeful to start hormone replacement therapy for other reasons, it can help your cholesterol. Of course, the cholesterol that you eat can help your cholesterol, so you want to watch that. Certainly getting lots of fiber in your diet binds up the cholesterols so that you can pass them through your system, getting good exercise, and then you could consider the supplement red rice yeast. So give that all a whirl. Cool. Hello, hello. So I'm going to go to the questions on the graphic. And so please don't hesitate to just keep popping them in on the side. So for one that was in the Facebook community graphic, I like this one. So this is Karen Fitzsimmons, and she's got a follow-up for me. So Karen was on our Ask a Doc call in the Extreme Menopause Body Makeover group. And we talked about different things with hormone replacement therapy there. So by way of bringing me up to date, things are much better. She has yet another revision of her prescription for hormone replacement therapy. I think our recommendations at the time was to go up in the dose because she wasn't getting better on the one that she had started. After 3 weeks of solid use, I'm tracking again like when I started. Perfect. Never miss one day again. You're not going to miss any of those doses. All those returning symptoms are gone. Beautiful, except for one. So Karen states, what about menopause rage? Tell me, is it a real thing or am I just losing my mind? Constantly angry about nothing and expressing it wildly. My husband kindly told me the other day that I've been raging for about 2 years after a bottle of unallowed wine. That was almost funny. So you can spare a minute or two any rage issues associated with menopause, please, of course. Or do I need a psychiatrist and not an OBGYN? Excellent point. As always, you're the best. Thank you. You got it, Karen. So it's a really interesting question. And I was thinking about it after I read it to say, like, what would I think that rage would come from? And I suppose that rage to me, and I could be wrong, everybody's going to is going to probably define it in a different way. So when I thought about it and tried to feel it, I feel like this like overwhelming sense of like irritability or anger, and you just have to blow off steam. And I think what Karen, you might be noticing, and what your husband's noticed, is you just don't have the same tolerance or resilience for things that annoy you. I think that, like when you're tired, you can struggle to respond appropriately to people. I'm sure everyone in here has found that. When you're sick, you can, and you're not feeling well, you have lower resilience and you're unable to maybe like temper your emotions. So it might in fact be, Karen, that you just need the hormones to start working better, get some good sleep, and then your emotions will settle down. The other thing to consider is, honestly, sometimes, estrogen can make you full of energy, and some women who are getting a lot more estrogen can feel anxious. So the physiologic way that I was thinking about this for you, Karen, was in one by way of your sleep, and the other is your balance with progesterone. So the other thing to consider with your hormones and your prescriptions is if you've been going up in your estrogen, have you been keeping in step with the progesterone, and did your estrogen kind of go over your progesterone? I'm not thinking that one as much because it seems to me that that's been a symptom for a while, but it is something to consider. So to kind of just like sit in yourself and feel if maybe that is something that might be helpful to you. And so it might be something to bring to your provider as you've adjusted the estrogen. Do you have to adjust the progesterone in kind to kind of just balance those things out? You might find, though, that the herbal supplement evening primrose oil is something that can be helpful for rage type symptoms, just the irritability. So I have had patients have good success with what I would find a similar symptom is that of like extreme PMS, or some women do have psychiatric diagnosis of PMDD, or premenopausal dysphoric disorder. Premenstrual dysphoric disorder. And so those are cases that can respond to herbal supplementation with evening primrose oil. Certainly magnesium, which is the magical stress vitamin, is a good supplement that can help with your emotions and, feeling that out of control type of feeling. And so if you're low in magnesium, and certainly it's a time in life when you could be low in magnesium, you might be feeling those rageful symptoms. So those are the things that I would try. But, even for PMDD, that is something that sometimes does require psychiatric medications because it just can't be treated with natural treatments. So the other thing to consider is, it's a good point. Do I need a psychiatrist or an OBGYN? I'd say I would focus on how well you've been sleeping now with your new regimen. I would then consider adding evening primrose oil and or magnesium, certainly magnesium, because it's good for all things. I would see how things are starting to settle as you're improving, and it's been a little bit longer than those 3 weeks of improvement. And if not, it would be worthwhile to talk with your provider about maybe the balance of your hormones and or maybe whether you do need something for more on the psychiatric side than the OBGYN side. So Karen, I'm so happy that you're doing better. Nothing delights me more than to know that it's been working out a bit better for you. And if they can be in any way more helpful, keep me posted on how you're doing and see if any of those things are helpful for you. Okay, so Lynn's question is next on the graphic, but I have another one live that I'm going to grab. And over here, Debbie asked the question that I'm going to pull up on the screen because this is such a clever one. There we go. Look at me. So that way the folks on replay can probably see the questions on the side here as well. So Debbie says, I am 65 and I have been in menopause for many years. I have low libido. Is there anything I can do to help with herbs or nutrition? I also deal with more inflammation. Need suggestions. So that is really a hard one to say. And so because women's libido is so, everyone's libido is complicated. I hate placating it. We're just going to say everyone's libido is hard for men and for women. So men, even in times of stress, are going to struggle with libido because stress will lower testosterone. So all kinds of stress, even for men, will lower their testosterone. And so they're very sensitive to it, of course, because it's the more major hormone in their body. But women, I think, complain of this more. There is a direct correlation between the drop in estrogen and lower libido. However, that being said, Debbie, I wish this is something I could tell you would be better if you start hormone replacement therapy. So many symptoms of menopause are improved by hormone replacement therapy, but there is a lack of evidence to show that hormone replacement therapy necessarily helps with libido. I shouldn't say that. Estrogen replacement therapy helps with libido. So you can see lower estrogen on the same graph. You can see libido go down concordantly with the estrogen levels going down. However, when you give a woman estrogen in hormone replacement therapy, it doesn't necessarily improve libido. Testosterone, however, is a hormone that can also be supplemented or replaced in the menopause replacement therapy. I don't have as much experience as I've admitted before prescribing it, but it is something that can be helpful. So you can directly supplement testosterone if you have a provider that is comfortable doing that for you. That is a suggestion. But if you're looking for natural things that you can do, so DHEA is an adrenal androgen that is, I wouldn't say controversial. I would say for as many times as I've heard that it is helpful, I've heard people say that it isn't helpful. Or maybe a little bit, I think what I heard favors more the good than the bad. But I would say that generally speaking, DHEA doesn't have many negatives, and it's an over-the-counter supplement that you can find easily. So DHEA is available in your vitamin section, and there has been some providers, some experts that believe that DHEA can be helpful. So you could certainly give that a try with very low risk and see if it is helpful for you. You'll notice that when you buy it, it comes as like a 25 milligram tablet or a 50. 100 would be a lot. I would say, if anything, I would start out at taking just a 25 milligram tablet. If anything, increase that to 2 of them and see if it's making a difference for you. So again, it's available in the vitamin shops. It's DHEA. It stands for dihydro something or other. Don't do that to me. Anyway, it's an adrenal androgen. It helps. It's a plant-based product that supports the androgens, and so it might be something that you find helpful, and so you can look at that. The other thing, though, that's really important, Deb, is that honestly, for all the things that lower testosterone in men and women, stress, for example, magnesium. Here we are again. Magnesium is the mineral of stress, and so if it's low, you can be stressing your system, and so you might actually find that it's helpful for you to supplement magnesium. Of course, getting good sleep is going to help your hormone balance overall. So if you want, just ensure that you're ticking all the boxes when it comes to sleep, exercise, and nutrition. Even before you run out and get the DHEA, I think the most important thing to do first is to optimize the things that you can control the most, right? So your diet, your exercise, and sleep. Because if you're saying, Deb, also you're dealing with inflammation, that also can be playing into your libido, lowering your testosterone levels that you would naturally be producing, because the ovaries still will make testosterone even after menopause. So you do want to just focus on optimizing those things also for decreasing inflammation. So all those things will go a long way towards also helping with libido. There are actually some pharmaceutical medications that are intended for the treatment of libido. They are as well variable for whether they're helpful. One of the medications called ADI was actually studied in premenopausal women, and it's been used off-label for postmenopausal women with some success. And then there is one that's an injection that, if you're game, is also pharmaceutically available for low libido. But ironically, both of those work in your brain, not on your hormones. But they are things that are out there for you. But I honestly, Deb, would say go back to the basics, optimize all those things that will decrease inflammation and hopefully naturally increase your testosterone levels. So Lori's question is itching normal with oral estrogen? I've been on oral under the tongue melts 5 weeks now and have itching in the last 2 to 3 weeks. Doc says to stay with it and it should lessen. So, I've never heard of oral estrogen causing itching. It might actually be something in the tablet itself, like maybe a filler or something that you're reacting to, because I don't think there's anything about the estrogen itself that would cause itching. Just looking through. So I would watch that very closely, because if you just want to watch that it's not an allergy to what you're taking, and I wouldn't necessarily think that it is normal. The other thing to consider is, an oral preparation of an estrogen is processed by your liver, and elevated bile salts can make you itchy. It's not too uncommon outside of pregnancy because they don't usually get that high, but you can have itchy skin from elevated bile salts. So it's certainly something that if it's not getting better, I would go back to your provider and ask them to look at a few of those things for you. Oh, I'm gonna say, here we go. As a follow-up, Lori says, I switched from the pellet to oral estrogen and progesterone and weekly testosterone shots about 5 weeks ago. So going from all of those products where you weren't having itching to now having the itching with the oral estrogen, I would just watch that it's not something that's actually in the tablet that you're reacting to, that or your liver now processing the medication over. Because if you're taking your estrogen previously in shots and such like that, where it wasn't an oral formulation, didn't necessarily need your liver. So you just want to watch for your liver. Just things to bear in mind. Yeah. So, Lori's saying, yep, no problem. Hysterectomy at 35, now 50. Yes, you've probably been on hormones for a long time. I know a lot of my patients who've had a hysterectomy we're on hormones for longer, and we talk about that before surgery. Perfect. You got it, Lori. Excellent. So just make sure I'm not missing anything here. I'm going to jump over here to the graphic and hit Lynn's question. So I don't know, Lynn, if you're here live on Facebook, because I can't see Facebook comments, or if you're listening on replay, but either way, Lynn says, hi, Dr. Rachel. First and foremost, thank you for being here. You got it. And patiently answering all of our questions. I love it. So thankful for all of you. I was wondering if stress incontinence is due to declining estrogen. It started for me about 3 years ago. I'm 64 and I'm currently on no hormone replacement therapy. It usually happens if I have too much caffeine or alcohol or doing strenuous exercise. What can alleviate this? So interesting, Lynn. It's I would say, you know, and it's hard to say because the two things happen at the same time. It's probably a function of aging. And then the decreased strength of the tissues, right, of the whole pelvis. So the muscle strength decreases, and the vaginal epithelium becomes weaker. So what I would say is that it is possible, though, that the lower estrogen levels in the vaginal tissues can make you more susceptible to those things. So vaginal estrogen might actually be a good alternative for you. There's certainly zero age limit to somebody starting vaginal estrogen. The amount that's absorbed into your system is actually quite low, and it's intended to treat the vaginal tissues. So I don't know if but you said that you're on zero hormone replacement therapy, but I wouldn't honestly call vaginal estrogen hormone replacement therapy. To me, it's topical estrogen and it's vaginal estrogen use. So you certainly would maybe an excellent candidate for vaginal estrogen use, and it could certainly be helpful with your symptoms. So that although you did cite two very important things. So caffeine and alcohol are very common triggers for bladder irritability. So it literally irritates the lining of the bladder. And now imagine all those tissues are thinner, right? Your vaginal tissues are thinner, and the vaginal and vulvar tissues are thinner. That leaves your bladder also the lining a little bit thinner, so it doesn't have that protective barrier. So caffeine can be very irritating to the bladder, as well as alcohol. So those two things are common triggers. And then it's a quality of life thing, deciding which is worse, right? It's like, oh, every time I have alcohol, my bladder goes crazy, but I would love a glass of wine. And so you just have to know that you're going to have a night that's a little bit harder than others. But I do think that if you talked with your provider about vaginal estrogen, that it might be something that can be very helpful for you, and make life far more worth living by being able to have a glass of wine when you want to and not worry about irritating your bladder. Certainly life for me, there is no life without coffee. So I wouldn't be able to avoid caffeine personally. So, but vaginal estrogen may be an excellent alternative for you. Stress incontinence is a little hard also if you've had vaginal deliveries, you're at higher risk. Pelvic floor strength can be helpful, but overall, it's hard to treat stress incontinence by just exercise alone, but you might find a good pelvic floor physiotherapist that can be helpful with stress incontinence symptoms. But the vaginal estrogen might be very helpful. There's been some use of other than surgeries, like some bulking agents for stress incontinence. So it's definitely worth seeing a urogynecologist specialist if you have that available to you, or urology specialist that specializes in women's incontinence. Perfect. So Deb adds here, do have a good diet and take magnesium. So I may check out this DHA. Perfect. See, excellent, Debbie. You optimize the things you can, and then it's worth adding the DHEA. I personally take it. So I would say that, Debbie, you don't notice right away, but I did notice, I think that I left it out of my regimen for a week. I couldn't figure out what was different. And I went back and added it back in because it's one of those things, it's very subtle. But I went back and put her back in. So to and it seemed to go back to how well I was feeling. So I have found success with taking it. And the only negatives I've ever heard from patient feedback is one woman was taking enough that she was getting acne from it. So I certainly don't recommend taking enough, because it does increase your androgens, taking enough to give you acne. So just watch for anything that might seem a little bit different as you start it. Perfect. Keep me posted. Let me know how you do. There you go. See, and Lori adds that she just started a DHEA 5 milligrams a few weeks ago as well. Yeah, it's certainly, it's kind of the testosterone cheat, because for those who don't, of us who aren't as well versed in prescribing testosterone, we're using DHEA as our cheat method, but and get a good success with it. So Marcy Fenton also put a question in on the graphic, and she put in, hello, Dr. Rachel, I'm Marcy. So happy we have you to reach out to. Perfect. I'm happy to. I am 50. I still have my regular cycle. I'm almost sorry for you. Sorry, I lost half my, just need to ask, now at 50, are there certain things I should be looking out for in my body? Should be looking out for that my body would be telling me. So for example, my sister, who is older than me, has night sweats, hot flashes. Will this be something all women experience? Our mother had horrible sweats day and night, and I appreciate your time and help. So Marcy, excellent for you that you haven't. Oh, perfect. Lynn, you're on with us. Excellent. So the, whatchamacallit, I used to say, I don't know, it's kind of, I guess, not planting too many things out in the world for manifestation. I guess I lost my. Oh, there we are. Expect nothing. That way, you can kind of just take it all as it comes. But sometimes, I think that we live in an era where we have a lot of information. We want to be prepared. We want to know what to look for. But I think that honestly, Marcy, if you have an idea of like what might be changing for you, you might be able to then step in sooner. So I would say now knowledge is power. And so that if you feel as though you're starting to experience changes in any and all of the things, then you may consider starting low dose hormone replacement therapy and eventually hormone replacement therapy if you are a good candidate for it. So what are the common symptoms of menopause? Well, I would say, honestly, the most commonly associated with menopause symptoms aren't necessarily the same thing as the most common menopause symptoms. And why I say that. So you'd say, well, I think that they're easily attributed to menopause. Having the classic night sweats and hot flashes are easily attributed to menopause. So they're thought of as the most common menopause symptoms. But the ones that are kind of sneaky are the ones that maybe weren't necessarily attributed to menopause or perimenopause. And so they don't get that kind of classic label. And those, you might just start noticing changes maybe in your sleep pattern. You might notice that you're not as refreshed when you wake up in the morning without actually having night sweats. And so like you might just not be a sweater. You might not be a person who gets night sweats or hot flashes in their sleep that causes them to wake up, but rather the quality of your sleep starts to decrease. And that loss of quality might represent just coming enough out of your sleep cycle that you're ruining the quality of your sleep, but not completely being conscious of being awake. So maybe changes in how you feel during the day, in the sense of you like, I don't know, I slept for 8 hours, but I still don't feel quite rested. It might be a sign that you are experiencing hormonal changes and maybe having those fluctuations in your sleep that aren't quite waking you, but you're having those things. And that might be a place where you say, well, I'm not sleeping well, so maybe I should consider something to help treat that. The other would be brain fog. So a very common symptom of perimenopause into menopause that's maybe not always attributed to menopause is brain fog or feeling just not quite as sharp as you used to, and or depression. So those things might actually be associated with your lower hormone levels. It might be treated by actually supplementing your hormones or hormone replacement therapy rather than with antidepressant medications. So those things to consider. Some might just notice changes in joint inflammation, and that might just be a sign of changing hormone levels before hot flashes and night sweats. Truth is it, it's true. It's easy to say that there isn't always, every woman isn't going to have hot flashes and night sweats, but they may have other signs and symptoms that they just never attributed to menopause. So I have had plenty of women tell me that they just stopped getting their period. Never had hot flashes, never had night sweats, no complaints that they know of. And then they just went into menopause and that was it. One day they had their period and the very next day they didn't. They try not to advertise because they're usually very unpopular with their friends, because most of them are like, people will look at them like, what do you mean? Like, you just stopped getting your period. That's the craziest thing I've ever heard. But it does happen to some people. But that's not to say they're not affected by menopause. So the other thing, though, that's like kind of the sneaky thing about menopause, Marcy, is just the changes that some will attribute just to aging. And so that might be changes in your cholesterol, as we were talking about before, or changes in your blood sugar that that just started to crop up in your late 40s and early 50s, or unfortunately finding out later in life that you have bone loss. So those are all related to menopause. So inevitably, Marcy, everyone will go through menopause. There will be some effect, whether it's profound enough to make you symptomatic or not. There will be some effect. At this point, it isn't as such that that people are recommended to start hormone replacement therapy absent symptoms. I think there might come a day where we recognize all of the prevention. Sorry, just fixing my buds. All of the prevention that comes along with starting hormone replacement therapy, especially early in menopause before health conditions have set in. But that's probably a bit of a different conversation. But and you see, Marcy, many people would say that your experience would be similar to that of your family, but so far you're holding out, and your sister and your mom have a different path than you when it comes to vasomotor symptoms or hot flashes and night sweats thus far. But just know that I'm here for you if you do notice any symptoms, and if things pop up for you, Marcy, and you just want to know, like, is this a menopause symptom, or should I look elsewhere? It probably is, but I'll help confirm that for you if you feel any of those things. But so keep us posted and try not to advertise, because you'll be very unpopular. Cool. So Tracy popped in a question over here. Okay, Tracy says, hi, Dr. Rachel. Thank you for your time. Of course, this is a pleasure. I do have a question about bone density. Yay. I love these ones. I used to actually give like essentially a 40-minute visit for bone densities. When you had your very first bone density, I would go have patients in the office to go over the very first bone density. What does it mean? What can I do? Because there's so much that can be done in the prevention side of osteopenia before osteoporosis, even in just general discussion with patients as they come in for visits. And I think it's as early as talking with patients in their 20s about what they can do to help protect their bone density, because unfortunately a lot of those changes that we see at 65 have already started at 25. So you gotta, this is a lifespan thing. Our bones are here forever. Sorry, that was my soapbox. So I'm 56, postmenopausal, vegan for 12 years, been weight training for 30 plus years. My T-score is minus 0.53. What can I do? Okay. Wait, let me get this right. So the T-score is that's actually not bad at all. What's the other one? Oh, your Z and your T. Okay. All right. I'm going to bring myself back to one of my consults so that everyone will understand we're on the same page. unless you're looking, they gave you a different number. Let me, so that I can go through this for you. So when any woman gets a bone density, it's essentially a bell curve. And so the, not a, okay. Hold on a second. Oh, they told you it's horrible. Okay. I'm going to assume we're talking about different numbers, and I'm going to, for this example, Tracy, put you on the side of the discussion where I would start giving you the talk. So when you look at a bone density, what it is literally the way that the x-rays penetrate your bones. And they take that bone density that's standardized on a special machine, and they have all these data from women of all ages, but they take the average, and the average is generally that of a woman of about 25 years old. And that's kind of where a woman develops peak bone mass. Everything on this side is lower than the average, and everything on this side is higher than the average. So if you're average, or you have a score of, oh, there you go. Tracy, that is bad. You have a score, if you're average, you have a score of 0. If you're better than the average, you're on the +1 side. And we have bars that we look at, and it's +1, +2, +3, +4. If you're +1, you're 1 standard deviation above the mean, +2, 2 standard deviations above the mean, et cetera, et cetera. We don't really worry about those people because they're spectacular. What we worry about are these folks. And so when your average, you're 0, remember, if you go to -1, -1 means you're 1 standard deviation below the mean. If you're -2, you're 2 standard deviations below the mean. And if you're -2.5, you're getting out to the curve where the curve starts to go like this. When you're 2.5 standard deviations below the mean, you actually now earn the diagnosis of osteoporosis. When you get to 3, you can see where we're going. Now, unfortunately, Tracy, your score winds up being in like what we would consider the fringes, right? These are the people who represent less than 1% of the population. So less than 1% of the population good, and less than 1% of the population bad. So unfortunately, that's a really hard place to come back from. But certainly not impossible. You can optimize that to the best that you can. So your Z score is -4. A T score is you versus women your age. So versus the score versus your versus women your age isn't as bad as versus the average person. So you have earned the diagnosis of osteoporosis. I think actually, Tracy, hold on a second. Pause. Was your test? Your test is done in the United States, right? Let me just look at something. I think I gave you that backwards. Hold on. Oh, yeah. Okay. Yes. I'm sorry. I thought I was speaking backwards. Okay. I thought I was speaking backwards. Yes. No, I am not speaking backwards. Okay. Your Z is you versus women your age. Your T is you versus the average 25-year-old. So that means that for comparing you to women your age, you're 4 standard deviations below the women your age. And then your T score compares you to the whole population. Anyway, nonetheless, you don't want to be less than everybody else. You want to be more than everybody else. There you go. Okay. So the T score diagnosis of osteoporosis is minus 2.5. The Z score is you compared to women your age. Anyway, so just to clarify that, speaking generally, the T score is for your osteopenia, osteoporosis score, and your Z score compares you to women your age. So I use that Z score when I'm comparing a woman to a woman her age who's not yet menopausal. So usually that's somebody who I'm doing their test because they are on a medication that I'm worried about. So in a young woman taking a medication that lowers her estrogen levels, I obviously comparing her to a 60-year-old woman isn't fair, but what I want to do is make sure that she's not losing bone in excess of women her age. So Tracy, what they're telling you is that your score is lower than women your age, but your T score of minus 0.5 isn't as bad as what it looks like as the Z score. Please let me know if I haven't completely confused you. Nonetheless, what can you do? That's the most important question that Tracy wants to know. What can you do about your bone density? So it's great that you're vegan. And that you're here with us means you've gotten the protein speech, because when you're weight training, you want to ensure that you're getting an adequate amount of protein. I think if anything, if I could try to make better for a lot of women, especially women that I've spoken to in the last number of years who don't get enough protein. And I would say we're getting much better. Right? This generation, our generation is getting much better because we've gotten a lot more messaging. The old RDA, the upside down pyramid, had put the carbohydrates at the bottom and the protein somewhere up at the top. And so unfortunately, we were having much higher carb diets than we need, and that protein we really need to support our muscle strength and our bone health, right? Because your muscle strength equals your bone health. And so many women I spoke to weren't getting enough protein in their diet. So increasing lean protein, and I encouraged a lot of plant-based protein to do that for my patients. And so that was one of the first things we want to work on. We need protein also to bind to calcium. So if we're going to take in calcium as a supplement or take in calcium from our diet, we need the protein in our diet to bind to the calcium. So the other part of the speech then becomes making sure you're getting enough calcium. So as a vegan, I'm certain that you know that you can get your calcium from green leafy vegetables, broccoli, and let me think of all the things that are vegan that have calcium. But all of the vegetables that grow in the soil, you're picking up calcium from the soils, and so you're getting a lot. So it's not to let anybody tell you that just because you're vegan, you don't get enough calcium because you don't drink milk. To be honest, the milk calcium isn't that bioavailable, and there's significantly better sources of calcium than that. If you're non-vegan, getting your calcium from salmon, from shrimp, actually those are the two meats that have the most amounts of calcium in them. So you get calcium in lots of things. You want to get calcium in about 1,500 milligrams per day. And if you feel as though you might just be falling short, it is okay to take a supplement, but you can only absorb 500 milligrams of calcium at a time. So like if you're eating more than that from a supplement at one time, most of that is going to be out in your poop because you can't absorb it. So you just want to have most of it from your diet. Is the most bioavailable. Vitamin D, so important. So I hope, Tracy, that somebody's tested your vitamin D for you. There's a high correlation if you live in an area that doesn't get enough sunshine with vitamin D deficiency, and in turn with osteopenia and osteoporosis. So if you look at graphs, they all directly correlate. So making sure that you have enough vitamin D and optimal vitamin D in your levels. So hopefully somebody will test that for you. So that's another place to go. And then like you've been doing, the weight training is fantastic, right? So putting stress across the joints increases the bone density across the joints. So as much as you can boost all the things around your training, Trace, by having the protein, getting the calcium, getting the vitamin D, that can help to increase your bone density. But as a vegan, you have another advantage. So if you're getting soy in your diet, so soybeans contain genistein. Genistein is a phytoestrogen that is actually quite good at helping to build bone. It acts in the bone the way that the bisphosphonate medications do. So bisphosphonates that you take, that you get as an infusion, they act to increase the osteoblast cells and decrease the osteoclast cells. So those are the blasts are the builders and the clasts are the eaters. So you want to keep the balance high for the blasts and low for the clasts. And so the phytoestrogen genistein does that. It's also in fava beans and other beans, other legumes contain genistein. So that's something that can help overall. But I would say just, Trace, is optimizing those things that the best you can. They might actually recommend, you got it. No, that you need to eat meat. No, 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 no. I would say I don't support that at all. So Tracy was just saying that everyone keeps telling her to eat meat, but there is, you can definitely build muscle as a vegan. You just have to focus on getting good sources of protein. It doesn't have to come from meat. There's no calcium in meat. I can't support that. So that's not necessarily the answer. And I'm certain that you could find the proteins that you need, the calcium, the vitamin D, and all those things without eating meat for sure. Yeah, it is kind of sad if your ortho tells you that his 90-year-old mom has better bones. But yeah, I mean, and part of that, to be honest with you, Tracy, is genetic. So like if you have a smaller frame and your bones are lighter because that's your genetic makeup, it kind of puts you at a disadvantage to have that. But it is, these are the things that you can control: is the protein content, your calcium, your vitamin D, exercise as you are, and those things. There's if you don't already do any type of rebounding exercise, that is supposed to be very good for bone strength as well. Just going to pop back here for a second. So Catherine says her new GYN switched her 1 milligram estradiol 1 milligram tab to dermal patch. Perfect. 0.35 milligrams bi-weekly on it for vaginal pain and osteoporosis. That is now osteopenia. How do I know if the dose is too strong? Dense breast last 2 years. So hopefully, they sound pretty equivalent to me, but hopefully your provider there is a calculator for the equivalents. So very clever. You can Google it. You might actually be able to Google it yourself, Catherine. There's a calculator that I've used to transition patients from one to the other. And it'll tell you what's the equivalent dosing of the estradiol tablet to the patch. So you see how, like, when you look at the size of those two things, the bottle, you're like, oh my God, it looks like you have so much more of estradiol in one than the other. They're actually probably pretty close in equivalence, but because a lot of what you're taking in that tablet isn't absorbed, the patch is right on your skin. So near all of what you're putting on your skin is being absorbed. So those probably are equivalent. They sound about right to me. That's probably about where I would start you if I was transitioning you from one to the other. I personally think that was a great switch because the patch is excellent. It actually has a lower risk of blood clotting. So a lot of providers have a lot more comfort prescribing transdermal preparations because they do not need to pass the liver, and it's passing through the liver that increases your risk of having blood clot. So I could see why your new provider encouraged you to change, and that's great. And it sounds like they're probably about the same. I don't suspect that it would be too strong. If anything, if you notice any symptoms, you might want to go to a slightly higher patch, but just keep a tabs on how you're feeling for sure. Dense breasts are Good and bad. The lack of density in your breast just means that it's been fat replaced. But it's usually also something that's more genetic. Your breast density, you can have dense breasts all the way up until your 80s and 90s, if that's your genetic makeup for sure. Density just represents the ratio between glands and fat in your breast. So if you lose an awful lot of fat, you could also, but in fact, make it seem as though you're increasing your breast density because of removing some of that fat. Okay. So Catherine was also saying she's been on Fosamax for 4 years, then Prolia shots, decided to just lift, rebounds, excellent, D3 and K2, magnesium and HRT since September 2022, DEXA in 2024 improved, hopefully still better, and DEXA 20. Perfect. Yeah. So Tracy, I don't know if they've spoken with you about these different things. So Fosamax is the bisphosphonate medication that we were talking about, that the genistein is similar to, and the Prolia is actually an antibody injection that will bind to those clast cells, and so that the clast can't act to reabsorb your bone. And so all those things together, Catherine, you're doing a fantastic job. I'm so happy for you. Oh my God, guys, I could keep talking and talking, and it's already 8:00. Holy cow. Oh my God. Okay. So, to be continued. So guys, that hour went by so fast. I am so excited for all the engagement. And as long as you guys want me back, I will be back in just about a month. And for those who are in the extreme menopause body makeover community, our call still rolls once a month in that group. I believe if you're in the app community and you do get the extra coaching add-on, I shouldn't say believe, I know, you have access to me through the Ask a Doc call through that one as well. And that is the in-between weeks. So 2 weeks from now, I'm going to be doing an Ask a Doc in the Extreme Menopause Body Makeover group. And then 4 weeks from now, I'll be back in this group for a live. So anytime. This went by so fast. I'm happy to do it as long as you're willing to come listen to me chat. So to our first hour, I've loved every second of it. Thank you so much. And I love the engagement, and I'm so happy that we're here together. And so I'll see anybody in this group coming up in 4 weeks, or if you're in the Extreme Menopause Body Makeover group, I'll see you in 2 weeks. And those who are in the app and want to add the coaching, so you can come hang out with me in 2 weeks. I love it. And I'm sure you'll be very welcome. Yep, Tanya, see you in 2 weeks. You rock. And I will see you all then. Have a fabulous night. Hugs and kisses. Be good. Bye-bye.